topics of surgery, that is skin tumors, and then followed by reconstruction and transplantation. Out of these three topics, the transplantation chapter, only 3 marks question has been asked. The principles of organ transplantation, under this, these three questions also will be covered. So I request you to go through the Manipal Manual of Surgery, where it's mentioned in around 1 pages. It takes around 10 to 15 minutes of read. I'll not be going to this transplantation part because it's a 3-mark question. So first we will be seeing through reconstruction chapter. In that, the two short essays has been asked: skin grafting types and uses, split thickness skin graft, and 3 marks questions are skin graft, split thickness skin grafting. I'll be going through skin grafting now. What is skin grafting? Skin grafting is a procedure where normal donor skin is transferred to the recipient deceased skin. Grafting is a procedure where the donor skin, normal donor skin, is transferred to the deceased area of the recipient. In skin grafting, we have 2 types. That is partial thickness skin grafting, or tierce skin grafting, or split thickness skin grafting. All 3 terms mean the same. And other type, we have full thickness skin grafting or Wolff's skin grafting. What is partial thickness skin grafting? In partial thickness skin grafting, the entire epidermis along with a part of dermis is transferred from the donor to the recipient. Whereas in full thickness skin grafting or Wolff skin grafting, entire epidermis with full thickness of dermis is transferred to the recipient. Let's see in deep what is partial thickness skin grafting and full thickness skin grafting. Based on the amount of dermis that is taken from the donor, the partial thickness skin grafting can be divided into thin split skin grafting, intermediate thick split skin grafting, and thick split skin grafting. What are the indications of split skin grafting or partial thickness skin grafting? The indications are: if we have well granulated ulcer. We saw in Burns chapter that after 3 weeks of dressing, we will proceed on to do split skin grafting. So a well granulated ulcer is a prerequisite. A well granulation tissue is prerequisite for performing partial thickness skin grafting. The indications are well granulated ulcer, the clean wound which can't be opposed. Is treated with partial thickness skin grafting. And following wide surgical excision, as in case of mastectomy, squamous cell carcinoma, we will be left with the large area of skin, defective area without skin. So in those cases, we can do split skin grafting. Now we saw indications of split skin grafting. That is a well granulated ulcer, non-opposable clean wound, and surgery where wide excision has been carried out. Now, what are the prerequisites for skin grafting? As I already told, we should have well granulation tissue. Along with that, if we have exposed bones, tendons, and joints, we can't do split thickness skin grafting in those patients. And if the wounded area, there is more than 10 to the power of 5 gram per tissue, 10 to the power of 5 per gram of a tissue, if beta hemolytic streptococci is more than 10 to the power of 5 per gram of a tissue, the patient will not be eligible to undergo split skin grafting because it undergoes infection after the split skin grafting and will be rejection of split skin graft. So we don't perform split skin grafting if the bone and tendons are exposed and if the beta hemolytic streptococci is more than 10 to the power of 5 per gram of tissue. Now, how to perform split skin grafting? The technique. We have a donor and a recipient. In the donor, where and all we can take the graft for split skin grafting. We can take the graft from thighs, arm, and legs. We use Humbee's knife. We use Humbee's knife to take the graft from the donor. So by using Humbee's knife, we will take the graft. The appearance of punctate bleeding in the donor will suggest that we have successfully taken the skin graft correctly. The method of taking skin graft has been successful is indicated by punctate bleeding. After that, we should do dressing at this defective area, and then we will open the dressing after 10 days. Now we have taken skin graft. We have to transfer it to recipient. That's why we take it from donor. First, we will scrape the wounded area in the recipient, followed by we will make the window cuts in the graft of the skin graft that we have taken from the donor. Why should we make window cuts? If we don't make window cuts, there will be seroma formation. To prevent seroma formation, we should make window cuts in the skin graft before transferring it to the recipient. The skin graft is then placed over the area, and then it is fixed with sutures. And most importantly, see, we do tie over dressing of the split skin graft. After placing a graft, we'll do tie over dressing. Now we have done split skin grafting successfully. In the recipient, we have transferred the skin graft. After that, after 5 days following surgery, we can open the dressing and we can look for whether there is any complications or whether there is infections and all, and we can treat adequately. This is all about the technique of performing split skin grafting, partial thickness skin grafting. What happens after that? What are the complications associated with split skin grafting? There may be contracture of the graft. Contracture. It is divided into primary contracture and the secondary contracture. What is primary contracture now? As soon as you take the skin graft from the donor, the skin graft which has been taken will contract by 20 to 30%. This is called as primary contracture of graft. Now, what is secondary contracture of graft? After the graft has been placed in the recipient, due to healing, there will be fibrosis and contracture formation. This is about the contracture of graft, one of the complications of split skin grafting. There may be seroma formation and hematoma formation under the split skin graft. There may be infection of the graft leading on to graft failure. And also, see, we have taken only the half of the dermis. So the hair growth will be impaired. The sensations will not be as good as normal skin in case of split skin graft area. These are all the complications. Now, what are the phases of graft uptake? What are the phases of graft uptake? Pay attention. The first stage, there will be plasmatic imbibition. What is the meaning of plasmatic imbibition? Between the graft and the recipient area, the fluid will occupy this area between graft and the recipient, which is called as plasmatic imbibition. Following that, a temporary fusion between the graft and recipient skin takes place, which is called as inosculation. Following inosculation, there will be neovascularization and the graft will be taken up successfully. What I told now, there is stage of plasmatic imbibition, followed by inoculation, followed by neovascularization and successful uptake of graft. This is all about split screen grafting. Now, what is full thickness or wolf grafting? In this, I already told that the full thickness of epidermis along with the full thickness of dermis is taken from the donor and transferred to the recipient. Where and all full thickness grafting is done, it's only done in case of face if the recipient has the disease in face, eyelids, and heads. Why so? Why this partiality to these areas? Because we can't afford contracture in face. It is cosmetically not acceptable to have contracture in face. And also in the eyelid, we can't have contractures because if the eyelid undergoes contracture, it may lead to entropyon. Following that, there can be epiphora. In the hands also, we can't afford contracture because we need skillful movement. Because of these reasons, we do full thickness grafting in case of face, eyelids, and hands because the chances of developing contracture is less compared to partial thickness skin grafting. The color matching between the grafted skin and the normal skin is good in case of full thickness skin grafting compared to split thickness skin grafting. Because we are transplanting whole of the dermis, the hair and the sensations are intact more compared to that of split thickness skin grafting. Now, what is the procedure that we do? We can take the graft from the patient's own post-auricular area, groin crease or supraclavicular area. We are taking the patient's own skin from the post-auricular area, groin crease or supraclavicular area. Following taking the skin graft, we will nicely remove the fat which is present in hypodermis. Remove all the fat present in hypodermis. Following that, we'll transfer this thickness graft into the area of defect, that is, which is in ear, face, eyelid, or hand. Now, we have now created raw surface in the areas from which we have taken the skin graft. Those areas we can do primary suturing or we can do split thickness skin grafting. This is about the technique of full thickness skin grafting. So, full thickness skin grafting, we saw one of the great disadvantages. We can only do full thickness skin grafting if we have only smaller defects. The advantage with full thickness skin grafting is we can take the the advantage with split thickness skin grafting is we can take the graft and we can increase the size by 6 times. By 6 times, we can increase the size by using a masher. So that is the advantage of one of the advantage of partial thickness skin grafting, where we can increase the size of the graft and we can cover larger area or larger defect. Where in case of full thickness, we can't do that. Only smaller defects can be covered. This is all about skin grafting. Let me summarize. We saw definition of skin grafting, following that partial thickness skin grafting and full thickness skin grafting. Partial thickness skin grafting, whole of the epidermis with part of the dermis. Full thickness, we take epidermis and whole of the dermis. In partial thickness skin grafting, we saw there are T types: thin SSG, intermediate SSG, and thick SSG. Indications are well granulated ulcer, clean wound, which can't be opposed, and then wide surgical excisions. What are the conditions we can't do SSG is exposed bone and tendons and the beta hemolytic streptococci more than 10 to the power of 5 per gram per tissue. What is the technique? From the donor, using the Humbee's knife, we take the skin graft where we see punctate bleeding, then we are happy. After that, we will go for recipient, we'll scrape the area and then we'll make a window cuts in the graft and they will place the skin graft. Following that, we'll do tie over dressing, and then we'll open the dressing after 5 days. What are the stages of graft uptake? That is plasmatic imbibition, inoculation, and neovascularization. Then we saw about full thickness skin grafting, which can be done in case of only we do usually do if we have only smaller area defects like face, eyelids, and hands. We take the graft from the postauricular area, groin crease, or supraclavicular area. Following that, we'll remove the fat and then we'll close the defect. Let's start with skin tumors. What are the previously asked questions? Previous year questions. We have pre-malignant conditions has been asked. More commonly asked question is malignant melanoma and basal cell carcinoma. And then BCC has been asked sometimes, and it's mainly asked as 10 markers. The malignant melanoma has just 10 markers many times. Marjolin's ulcer we discussed under venous ulcers. So let's discuss first pre-malignant conditions of skin, followed by malignant melanoma discussion. Let's start with the discussion. What are the pre-malignant conditions that we see in case of skin? First, we have Bowen's disease. What is Bowen's disease? Bowen's disease is a pre-malignant condition characterized by the clear cells in the epidermis, and also hyperkeratosis and parakeratosis. What is this hyperkeratosis and parakeratosis? Hyperkeratosis is increased thickness of stratum corneum. Parakeratosis is presence of nucleated cells within the stratum corneum, which is not usually seen. So Bowen's disease is characterized by presence of large clear cells within the epidermis, hyperkeratosis and parakeratosis, which manifests clinically as brownish, indurated, well-defined edge lesion. A lesion with a brownish induration and having well-defined edge is seen clinically. Why does Bowen's disease occur? What is the reason for Bowen's disease? For the person to develop Bowen's disease? Chronic solar exposure, that is chronic exposure to sunlight, and a HPV-16 infection is been associated with Bowen's disease. In 10% of patients, Bowen's disease may lead on to cause squamous cell carcinoma. Now, what is the treatment of this disease? We do surgical excision of the lesion with 4 mm margin, and then we can apply topical 5-fluorouracil. This is about one of the pre-malignant conditions, that is Bowen's disease. We also have other condition which is developing due to sun exposure, that is solar keratosis or actinic keratosis. Solar keratosis or actinic keratosis is a condition due to exposure to UV light sunlight, chronic exposure to UV light sunlight, leading on to hyperkeratosis. Hyperkeratosis is increased in thickness of stratum corneum, leading on to scaly lesion. It is usually seen in more than 50 years of age. If on top of this scaly lesions, if you see non-healing ulcer, if you observe induration, on clinical examination, if you see regional lymph node enlargement, then you should suspect malignancy in actinic keratosis. We discussed 2 conditions which are due to sun exposure. Those are Bowen's disease and actinic keratosis. Let's proceed on to third disease, that is radiodermatitis. What is this radiodermatitis? The term is self-explanatory. In the persons who are working in radiology department, who are exposed to radiations, they were developing previously the erythematous skin lesions, which eventually led on to squamous cell carcinoma in some patients. This is radiodermatitis. Nowadays, it is not common because of use of safety measures and materials to protect themselves, gowns and all. Due to this reason, nowadays this is rare. Radiodermatitis. Then we have Paget's disease of nipple, one of the pre-malignant condition. In Paget's disease of nipple, we see plaque-like erythematous lesion. The most accepted theory of cause of Paget's disease of nipple is the spread of cancerous cell from the intraductal carcinoma to the skin through lymphatics, leading on to the deposition of malignant cells in the skin and development of this lesion. So, on clinical examination, if you see Paget's disease of nipple, it signifies underlying intraductal carcinoma or ductal carcinoma in situ. Remember this point. And we saw the chronic scar or the chronic venous ulcer can lead on to Marjolin's ulcer. So this chronic scar is one of the pre-malignant conditions. We discussed about pre-malignant conditions of skin. Two, due to sun exposure, that is Bowen's disease and solar or actinic keratosis, radiodermatitis, Paget's disease of nipple, and chronic scar. Malignant melanoma. The term itself tells malignant melanoma, malignancy involving melanocytes. The epidermal melanocytes, which are present in stratum basale, if these cells undergo malignant transformation and produce the malignant lesions due to proliferation, uncontrolled proliferation of this epidermal melanocytes, it is called as malignant melanoma. It is the most aggressive skin tumor to have. What is the etiopathophysiology behind malignant melanoma? Before discussing about risk factors, let us see what are the sites where we see malignant melanoma commonly. We see malignant melanoma commonly in head and neck region, trunk region, and lower limb with 25% each distribution. Other left out 15% we see in other sites of the body. What are the risk factors of malignant melanoma? The risk factors are sun exposure, exposure to UV radiations. The white-skinned people are 20 times more sensitive to sun exposure, leading on to develop malignant melanoma compared to dark-skinned people. What are the skin conditions which are risk factor for developing malignant melanoma? The skin conditions can be broadly divided into the conditions which affects melanocytes and other conditions. The conditions affecting melanocytes are nevus. What is this nevus? The nevus is a lesion that you see. Commonly, you would have seen. Many of us have this. Nevus is a skin lesion produced due to increased proliferation of melanocytes. That's it. No dysplastic changes, no atypical changes in this. Only increased proliferation of melanocytes lead on to nevus. There we have different types like junctional nevus, large congenital nevus, and others. The junctional nevus and large congenital nevi more than 20 centimeter are the risk factors for developing malignant melanoma. We have another important risk factor for malignant melanoma, that is familial atypical mole melanoma syndrome, FAMMS. What is FAMMS? We say the person to be having FAMMS when one or more of the first degree or second degree relatives of the patient has malignant melanoma. Along with that, the patient should be having atypical mole. What is atypical mole? Atypical mole is a mole in which the patient has more than 50 nevi in his body. Out of those 50, at least 3 nevi have size more than 6 mm and should have the shape which is irregular and the color which is varied, not same color. See here, the normal, same color. The dysplastic ones will have varied color. So if the patient has first degree, second degree relatives having malignant melanoma, more than 15 AY, in that more than or equal to 3 AY, having size more than 6 mm, with the shape that is irregular and varied color, is called familial atypical mole melanoma syndrome, FAMMS, which is established risk factor for malignant melanoma. These FAMMS patients are more prone to develop pancreatic carcinoma in future. Now we discussed the melanocytes, the skin conditions associated with melanocytes, which are risk factors of malignant melanoma. What are the other skin conditions which are risk factors for developing malignant melanoma? Those are albinism and xeroderma pigmentosa. Xeroderma pigmentosa, albinism, we all know that there is depigmentation in the skin. It is a risk factor for malignant melanoma. Now, what is this xeroderma pigmentosa? Xeroderma pigmentosa is an autosomal recessive, genetically transmitted condition where there is defective DNA excision repair mechanism. When there is defective DNA repair mechanisms, the mutations go on accumulating inside the cell, eventually leading on to malignancy. So due to this reason, the patient can develop severe UV intolerance. He has severe intolerance to UV light, and the patient will have clinically severe sunburns, pigmentation which is severe, and erythematous lesions on exposure to sun. Along with these, the patient will have severe corneal ulcers, and also the patient will have many other malignancies because here the DNA excision repair mechanism is impaired. Along with malignant melanoma, the patient can develop many other malignancies. This is about the etiopathophysiciology of malignant melanoma. There we saw the risk factors: sun exposure, nevus, junctional and large congenital, and FAMMS, and other skin conditions like albinism and xeroderma pigmentosa, leading on to malignant melanoma. Now, what are the types of malignant melanoma? The types of malignant melanoma are divided into 4 types. Those are superficial spreading type, nodular melanoma, lentigo melanoma, acral lentiginous melanoma. Let us see each one of them in brief. The superficial spreading melanoma is the most common type of melanoma that we see in case of 70% of patients, and it has been associated with good prognosis. The superficial spreading type, as the term suggests, the malignant cells spread horizontally. So the name superficial spreading melanoma. There is a radial spread of malignant cells, and commonly we see superficial spreading melanoma on top of pre-existing layers like junctional layers and all. And it's most commonly seen in young patients, and sun exposure is one of the risk factors for this. This is about superficial spreading melanoma. Let's go on to nodular melanoma. The term itself suggests nodular melanoma. The skin lesion is nodular. What is nodule? Nodule is the skin lesion which has length, breadth, and depth. Because it is nodular, the growth of the tumor is vertical. Here we saw it's horizontal or radial spread. Here it is vertical spread, vertical growth of the tumor. And commonly we see nodular melanoma in the mucosal or mucocutaneous junction. In the mucus area or mucocutaneous junction, we see nodular melanoma. And the lymph node spread is very common in case of nodular melanoma. Since lymph node status is one of the important prognostic marker of prognostic marker deciding the prognosis of the patient. And also we see nodal spread commonly in case of nodular melanoma. We see worst prognosis in case of nodular melanoma. And it's the second most common type of malignant melanoma. The third one we have lentigo melanoma, lentigo maligna. The lentigo maligna is a brown macule or lentigo, macule-like lesion, not nodular and all. It's a macule-like lesion, and it is slow growing and variegated appearance. It is common in face and other regions. And we see commonly lentigo maligna in old age patients, and it's the least malignant type of malignant melanoma. The last type we have acral lentiginous melanoma. Acral, the term suggests, we see lesions in palms and soles of the patient. Here, most commonly the lesions present are flat, irregular macules, and also the patient may have nodular lesions. It also has poor prognosis. So we see types of malignant melanoma, that is two types which are most commonly seen in young patients, that are superficial spreading and nodular melanoma. Superficial spreading is most common time, followed by nodular melanoma. Then we saw lentigo maligna in old patients and acral lentiginous melanoma seen in palms and soles. This is about the types of malignant melanoma. Let us see the clinical manifestations seen in case of malignant melanoma. What are the clinical manifestations? The lesions can occur de novo, or it can occur on top of previously existing skin lesion. In 40 to 50% of patients, the malignant melanoma lesions occur de novo, that is fresh. The skin was normal previously, now he has developed the skin lesion. In 50 to 60% of patients, the patients develop malignant melanoma on top of skin lesions like junctional nevus. This is the junctional nevus. We have seen this in our daily life. Many of us have this. Many of our relative also has these lesions, junctional nevus. Now, what is the characteristic of the lesion of malignant melanoma? There is varied pigmentation, that is multiple colors inside same lesion, and there is irregular surface and margin. Margin is irregular, surface is irregular, and this lesion shows rapid growth with itching. With rapid growth, the lesion may eventually ulcerate and bleed. These are all the features of the lesion that we see in malignant melanoma. That is varied pigmentation, followed by irregular borders, irregular surface and margin, and then rapid growth of the lesion, which may eventually have ulceration and bleeding. We characteristically don't see induration, that is fibrosis, underneath the lesion in case of malignant melanoma. How do these lesions spread? The spread is most commonly by lymphatics. Spreading from, let's take an example where the patient has nevus here. Spreading from nevus to lymph nodes, the lymphatics will be involved, leading on to in situ lesions here on the tract of lymphatics. Will have the lesions giving it. These are called as not in situ lesions, in transit nodules in melanoma. These are called as in-transit nodules. The in-transit nodules in melanoma are the nodules present between a lesion and enlarged involved lymph nodes due to involvement of the lymphatics carrying the malignant cells. This is in transit nodules. These are in transit nodules. There can be blood hematogenous spread of the lesion. The tumor may spread most commonly to lungs, leading on to secondary cannonball lesions inside the lungs. The patient may have hemoptysis due to spread to the lung. Due to spread to the liver, the patient may have ascites. Due to the spread to the brain, the patient may have convulsions. If the lesion is too small, the patient may present to you clinically with secondary metastatic features. Very bad disease. This is about the clinical manifestations that we see in case of malignant melanoma. What are the investigation and treatment that we do? How to manage this condition? First, we have biopsy of the lesion. When you do biopsy of the lesion, you'll see malignant melanocytes in the dermis and epidermis. And then if you do immunohistochemistry in this biopsied lesion, characteristically, the Milan A, HMB45 and S100 markers will be positive in case of malignant melanoma. And then we can also do chest X-ray to see for lung secondaries, USG to look for involvement of liver. Then we can also do CT and MRI, PET-CT scan for detecting secondary spread. We have treatment of malignant melanoma. What is the treatment of malignant melanoma? We divide it into two. If the patient has localized disease without any metastasis, or the patient having metastasis. The localized disease is treated by surgical excision of the primary tumor and excision of the lymph nodes if they are involved. While excising the primary lesion, we have NCCN criteria. NCCN criteria says if the size of the lesion is less than 0.5 mm, the margin that we should take is 0.5 centimeter. If the lesion size is 0.5 to 1 mm, we should take the margin of 0.5 to 1 centimeter. If the lesion size is 1 mm to 2 mm, we should take the margin size as 1 to 2 centimeter. If the lesion size is more than 2 mm, we should take the margin as 2 centimeter. This is about NCCN criteria. Before continue, let's see the staging of malignant melanoma. We have Clark's staging and Breslow's staging. Clark's classification or staging is based on depth of involvement of the structures. It is stage 1 if the melanocytes only involves epidermis. It is stage 2 if it involves papillary dermis. It is stage 3 if it involves dermal papillae, that is this one, dermal papillae. It is stage 4 if it involves reticular dermis. It is stage 5 if it involves subcutaneous tissue. Very easy classification, Clark's classification. Then we have Breslow's classification based on the size of the lesion 1, 2, 3, 4. Stage 1 is less than or equal to skin lesion less than or equal to 0.75 mm. Stage 2 is skin lesion between 0.76 to 1.5 mm. Stage 3 is skin lesion between 1.5 mm to 4 mm. Stage 4 is skin lesion between more than 4 mm. So we were talking about treatment of the localized disease where we excise the primary lesion. Following that, we'll check for status of lymph node. If the lymph nodes are not involved, we'll do sentinel lymph node biopsy. If the lymph nodes are involved, we can do lymph node clearance. If the malignant melanoma is locally advanced malignant melanoma, we can do isolated limb perfusion chemotherapy. Just remember this point. If the patient has distant metastasis, we treat the patient by giving dabrafenib, that is BRAF inhibitors, trametinib, that is MAPK pathway inhibitor, and then in ipilimumab, that is checkpoint inhibitor. All these work by reducing the proliferation of melanocytes or the tumor cells. So to summarize, malignant melanoma, we saw etiopathophysiology. We see most commonly in head and neck region, trunk region, lower limb. The risk factors we saw sun exposure, nevus, and other skin conditions like albinism, xeroderma pigmentosa. We briefly discussed about familial atypical mole melanoma syndrome, FAMMS. Following that, we saw types of malignant melanoma: superficial spreading nodular melanoma, lentigo melanoma, and acral lentiginous melanoma. Following that, we saw clinical manifestation, the lesions which can occur de novo or on junctional nevus. The lesions are varied pigmentation, irregular, and rapid growth. The spread through lymphatics, in-transit nodules, metastasis to liver, lungs, and CNS. Following that, we saw investigation, biopsy, IHC markers, chest X-ray, USG, CT, MRI. And then following the treatment, localized disease, we excise based on NCC and criteria, lymph node clearance if it is involved. And in case of metastasis, we give ipilimumab treatment or trametinib treatment or dabrafenib treatment. If the patient has locally advanced malignant melanoma, we do isolated limb perfusion chemotherapy. This is all about malignant melanoma.